So the presentation that I gave yesterday was on validation of the ELN 2017 risk classification for AML. This risk classification system has been widely adopted since it was published 2 years ago. It's also taken up by the US NCCN guidelines. However, this system for classifying patients into different risk groups hasn't really been validated in the original publication where it was proposed. So that prompted us to go back to our own cohort of patients who were treated with induction chemotherapy, which actually span a quite broad age range in our study group, so up to patients over the age of 80, and try to see what this new risk classification actually changes, especially in comparison to the old 2010 system. And so the main differences that we found is ELN 2017 includes a couple of new high-risk markers, including RUNX1, ASXL1, TP53 mutations, high allelic ratio, FLT3 ITD. So as an effect, if you use this new classification, you will identify a lot more patients who are adverse risk. And especially if we look at patients over the age of 60, more than 50% of these patients can now be identified as adverse genetic risk. Now then, of course, we looked what does that mean in terms of patient outcomes. And if we stay in the younger age group, so below 60, favorable risk patients have about 60% chance of 5-year survival. The intermediate risk group are around 40%, and the adverse risk group are roughly around 20%. However, if you then look at the age group over 60, there's a dramatic downward shift in the outcomes, and the adverse risk patients who are over 60, the favorable risk patients who are over 60 only have a below 40% chance of 5-year survival. If you're intermediate risk, you're below 20%. If you're adverse risk, your 5-year survival is below 10%. And now keep in mind, this is 50% of our older patients. So we think this analysis really helps us to identify the groups where we need to do work and come up with better therapies.